Welcome to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom, and we'd like to thank today's episode sponsor, Takeda Oncology, for their support. Now, we are wrapping up our Muscles for Myeloma campaign, which we've run through March and April, which has been a fitness campaign encouraging myeloma patients to get more fit. We did this because we heard doctors, several and actually many doctors, talking about how they were segmenting patients into fitness categories, fit, unfit, and frail, and basing treatment options based on those fitness levels. And we had wonderful sponsors of Sanofi and Takeda Oncology and Celgene Corporation for that campaign. So we're grateful to them, and we've had hundreds of you getting fit in the last couple months. And also helping raise funds for the Myeloma Crowd Research Initiative. So thank you to all those who have participated, and we'll be finishing that on April 30th. We also have another important announcement. We are hosting day-long patient meetings for patients to meet up with top myeloma experts. The first will be held on May 7th in Salt Lake, and the second will be held June 18th in St. Louis, with future meetings to come that are kind of in the planning stages. Now, 3 experts will be attending in Salt Lake, and about 6 will be attending in St. Louis. These meetings will highlight important topics like immunotherapies, high-risk genetics, and effective strategies for relapsed refractory myeloma patients. Now, we have a special focus for high-risk patients because largely they are ignored, and many of the therapies will fail them earlier than other patients. So because we also all become high risk as our disease progresses, these meetings are really for us all. And there are early bird discounts available. So check out the Myeloma Crowd website, and you can register today for some truly incredibly important information that is personally applicable for you. Now on to today's show. So as part of this Muscles for Myeloma campaign, we met up with Melanie House, who is a physical therapist at the University of Iowa. She attended Pat's Myeloma Survival School last month, and she was on hand to talk about how to treat your body. Basically, a lot of myeloma patients, we go through treatment, and we just think to ourselves, what just happened to me? I hurt, or I feel so tired, or how do I get my body back? So here to help us understand more about that is Melanie. So welcome, Melanie.
Thank you so much.
Let me just give a little brief introduction for you before we get started. Melanie House is a clinical specialist for the adult bone marrow transplant, cardiology, organ transplant, trauma, gastrointestinal, colorectal, and vascular surgery services, and outpatient wheelchair seating at the University of Iowa. She is on the faculty of the graduate program for the university in physical therapy and rehabilitation science. Now, she recently won the University of Iowa Nursing Recognition Award for collaboration on quality improvement in 2015. She is a member of the acute care section of the American Physical Therapy Association, and she is a regular speaker at events, including this Pat's Myeloma Survival School that she attended this year. So, Melanie, why don't we just start? A lot of patients just want to know, what is it about myeloma treatment or having myeloma that makes us feel so lousy? That's a very broad question, but I know we'll get into a few more details.
Yes, I think we can break this down into some different specific areas that depend on the point of your care that you're in. So, my area of focus, I typically am working with people who are coming in for transplant, and I'm seeing them, of course, if they return to us with any complications. And here at the university, we have a program where folks are signing up for tandem transplants, which is back-to-back transplants within a 3-month time period. I mean, they complete the first transplant and come back 3 months later. And so that's the main group that I am familiar with, is more the inpatient side and preparing them to discharge to home. So I just wanted to get that out there. And just real quick, I wanted to say that any of the recommendations that I talk about here, they're not meant to be an automatic cure-all that people listening in can just turn around and start doing these things. You should absolutely meet with your local practitioner, work with a qualified physical therapist, if it's exercise, so that you are doing things correctly so you don't cause yourself more harm. So specifically, I think the first thing that I would just want to talk about is decreased strength. So we can quantify strength in a lot of different ways, but specifically if we look at what happens to the muscle when you are undergoing treatment for multiple myeloma, the first thing I would point out is dexamethasone is going to be a regular intervention that you'll be taking. And that is a steroid that, unlike the steroids that home run sluggers are using, which are anabolic steroids, which make the muscles bigger, the corticosteroid is catabolic. So it breaks down muscle and it actually prevents new muscle from being built. A person might notice that they are having difficulty rising from the chair or the toilet, or they may even not realize they're having difficulty because they're relying on their arms to do this. Some of my patients notice that they have trouble clearing a step or clearing their toes. They might have trouble flexing the hip enough to place their foot on a step. Those are some kind of early indicators that a person may be experiencing corticosteroid-induced myopathy. Now,
and do you see that in different dosing too? Because I know some patients are on a heavier dose of dexamethasone than others.
Right. So the thing that I've observed is it can occur with high-dose corticosteroid over a short period, or even people who are on low-dose chronic corticosteroid. And I see that with some of my patients I've worked with in other areas, such as solid organ transplants, so liver and renal transplant patients. You see it with your COPD population that's on chronic steroids. And so it is something that does not have to be at a high dose to have the effect.
And is it a cumulative effect as well?
Well,
or
I
do
do
you notice
think
that it's... Mm-hmm.
What I do notice, what I would point out is that for a lot of my patients, we're working together on the inpatient side, and this might be patients other than multiple myeloma diagnoses that are also taking this drug. But they would say to me, they told me they're going to cut back on my steroids today, and the first thing I inform them of is, first of all, that's wonderful, thank goodness, it's going to make our work easier, but we shouldn't expect to see that benefit tomorrow. Like it could, I see almost like about a week's lag time even before I would say I'm starting to see maybe that we're turning the corner with improving in functional strength. And that's just based on my observation in this, limited setting.
Mm-hmm. Is there anything else about Dex that you want to share?
I'm not a pharmacist, so I don't really have too much more that I would say about Dex other than I would encourage patients, you are consumers, you are people that are undergoing treatment to benefit the quality of your life and give you more quality days of living, that you need to be vocal if you're finding changes in your body that are causing you to lose your quality of life, which could be the level of dexamethasone, could be even sometimes doctors can back off a little bit on the intensity or the type of chemotherapies to prevent the severity of peripheral neuropathies. You need to vocalize that. Don't just assume that you should take, the full brunt of whatever the complication might be, because we have to find a balance.
Mm-hmm. And I agree. And I think for most patients, when we start with therapy, some of these side effects happen to us, and we kind of think, well, this is just part of going through this treatment. So I'm not going to say anything to my doctor because doesn't everybody have this happening to them? And maybe I'm just going to sound like a whiner or something. But I think what you're saying is that.
Yes, and I think to take that a step further, if you go to your physician or your nurse practitioner, that's your first encounter, and you say, look, I just wanted you to know that I'm really noticing I have trouble with these different things, whether it's getting up out of a chair or tingling and numbness from the chemotherapy. And you need to really tell them, look, I'm really worried about this. What can be done? Would it help me to work with a physical therapist to address these balance and strength concerns, proactively? And what can you do on your end? Can this be changed in any way? I'm just concerned about my long-term function.
Mm-hmm. I agree, and the sooner the better. And I don't think anyone will call you a whiner. I should have spoken up much earlier, and I think dexamethasone is probably everyone's least favorite drug that they're taking. And I even wrote a song about my my love-hate relationship with dexamethasone.
Did your song
awful.
include anything about how hyper you were when you were on the high dose steroid and you could have cleaned your house in a half an hour? I have. That's one other thing about my acute care patients is sometimes when they get that burst of the high dose corticosteroid, I literally can see them coming down the hallway and know that they're on steroids today. Like their pace is faster, they're talking really fast. They're like, "Oh, I could do anything. Can you show me more exercises?" Blah blah blah, and then the next day, crash. So that's another thing to be cautious about is that is sort of a front end. Some people will think it's a benefit, but again, you're going to have the back end consequence potentially of breaking down muscle.
Mm-hmm. And I think the more that we understand what's normal, what's expected when we take some of these things, it's kind of comforting. Mm-hmm. I think it's very comforting for patients to go, oh, this is normal. This is how everyone feels. Everyone gets really crabby on the dex and feels like they could, they're OCD about cleaning their bathroom. Mm-hmm. But let's talk about other things that affect decreased strength, because dexamethasone is one of those things. But you have some other things on your list as well.
Yes. When I meet my patients, I'm actually consulted to meet with them when they first arrive. So I usually can start my evaluation within 24 to 48 hours of their admission. And I always know that I have a bit more of a challenge ahead of me when I walk in and I see the patient who feels absolutely fine, laying in a hospital bed, watching television, and they're in their fuzzy jammies and their bunny slippers. And that's the individual that I'm going to spend that extra time emphasizing that today is a day when we need to get moving. They need to be as active today as they would be had they been at home. If you would have walked the dog 3 times today, let's get out and walk the dog in the hallway. Because what studies have shown, and we can thank our federal government and our tax dollars for this, but we have paid healthy young men 18 to 21 years old to lay in bed for 35 to 55 days and do nothing. And this is so that we could determine the effects of weightlessness for space travel. And these young, healthy men who are not getting chemotherapy, not getting dexamethasone, they will show upwards of 20 to 25% loss of strength in their lower leg muscles and upwards of 36% muscle mass loss, for example, in the calf muscle. So that is, I come with the hard evidence with my patients. If I get any pushback, people saying, well, I don't have any concerns about stairs, I can do those fine, or, I was healthy coming in, I'm not worried about it. I will come around and hit them with some of the available evidence of the secondary complications of just being immobile. And then nutrition obviously is a big factor. If you read even the basics on nutrition, if our muscles are demanding, our whole body is demanding energy, but our brain is the control center, and if the brain recognizes there's not enough energy stores available in the body, it will authorize the breakdown of muscle so that it gets fed. So those are some of the key things that I think about that contribute to the loss of strength. And I honestly can tell you, this is, again, I'm sure available in the evidence if we look at what chemotherapy side effects are. But I meet people every day coming in for transplant who tell me, I've lost 20 pounds, 30 pounds of muscle mass since starting their initial treatment, and they're not even in for transplant yet. So that suggests to me that it's more like that chemotherapy no doubt has, it's cytotoxic. That means it kills cells, and that is damaging to the muscles as well. Because many of those people, they're not on very much for steroids, they're still eating fine, can't really find a good explanation. So that's yet another thing that is a necessary consequence. I mean, you have to have that chemotherapy.
Mm-hmm. So a couple questions on that. When you said the healthy young men were losing this strength, how many days was that again?
Well, there's a couple different studies that I quote, and the one study was 35 days, and the other one was 55 days. And there are studies that are shorter duration, but these two studies just really looked at more of the variables that I was looking at as far as loss of muscle mass and loss of actual strength. And there are a lot of other things.
And how long is the average inpatient? Let's say I know a lot of places do outpatient stem cell transplants. What's the average stay for an inpatient stem cell transplant
I
for
think
a myeloma patient?
Yeah, the average stay. I mean, I didn't look this information up, so don't quote me, but I think we tell folks they need to really be thinking, somewhere between or up to 3 weeks would be a pretty realistic average. So, and we do bring people in ahead of time for most of our transplants, so they come in and do all their pre-med workup before they actually get the transplant. So they're with us a good 4 or 5 days, probably before transplant.
So you're almost to that 35 days.
Yeah, and it certainly can stretch out more for folks that might have difficult. The big thing really, I usually keep people to where they need to be physically, but they're challenged with eating enough, they're challenged with drinking enough to be able to get off the IVs and go home.
Okay. Well, your healthy young men might sound like my teenage sons on the weekend.
Right.
So we need to get everyone up and moving, which is why we created the Muscles for Myeloma campaign. It was just really critical that even though, and this 3-week time when you're having transplant, you feel the worst. You don't really want to get up and get moving.
Right.
You kind of want to say, I really just would rather lie here, thank you very much, and have somebody come and bring me some food.
and that reminds me of something you had asked me ahead of time. How do you motivate people who otherwise they just can't, the thought of getting up is enough to wear them out. And I find that what really works for my patients is, I come into the room with a spirit of sympathy or empathy and knowing what they're up against. I've seen it in so many people, and I know as they approach 0.0 for white blood cell count that the mere thought of getting up is exhausting. So for those patients they want to do something, they really do want to get up, I'm right there putting their slippers on for them. I'm helping them with their hand hygiene and putting the gloves on and managing the lines and the IV pull and just removing all other possible barriers that could slow them down. And that has shown to be really effective because literally if I stood back and said, well, they should put their own shoes on, they should do this themselves, they should do that, honestly, some of them would have already just laid back down. And so I think by being supportive and acknowledging that, you're really going to fatigue quickly, let's really conserve our energy for the important thing we want to accomplish here, and also setting more realistic goals. So when they first check in with me, I'm telling them they need to be out walking 3 times a day, and to do a minimum of about 1,000 feet each walk. And that is a minimum. But I set that minimum so that it's not so jarring to them when those counts get low and they look at that and go, oh my gosh, I'm failing. It's just it's just considered very minimal community distance. So being realistic with them and having a backup plan and recognizing what is possible today and the little victories that we can accomplish today and that this is a temporary state that we're getting through.
So I think that's helpful advice for caregivers, too, as we have caregivers listening in, and they want to help the myeloma patients as much as possible, and they want to motivate them or encourage them. So they could say, let's go on a walk together, and I'll help you get ready, and we'll keep it short, and we'll try to do a little more tomorrow. And then I know there are certain days during transplant where you're just, really slammed. Your counts are at their lowest, and you need to be very cautious about your safety, too. So when you say you have patients come in, do you stage like when you're having them get up and move, or do you wait till those critical days are over and then you start kind of building back up again, or how do you handle that?
So again, at the initial evaluation when I meet them, it is largely an educational session. I have my monologue that I go into. I mean, I interview them about any issues they're coming in with, what things are limiting them in terms of strength or endurance or possibly pain issues or pre-existing problems, and then letting them know kind of here's what the introductory package is. This is what everyone on this unit is being asked to do, and it's kind of a minimal expectation that you can do this, and if there's any reason you cannot, let's talk about how we would modify this. And then moving forward, I can tell them that I am there as a resource to them. And if they have any questions or anything new comes up, that I am to be paged, but I will reappear without fail when their counts approach 0.0. Because it's at that time when we really do need to revamp the program, and I'm probably teaching them some exercises to do in the room. Because something I should mention, and I don't think these are giving away secrets by any means, and everybody needs to benefit from this. But if you look at the limited research that's been done on bone marrow transplant and exercise, the thing that I see that I feel is a shortfall for our patients is we're not really challenging their lower extremities enough for strength training. So you'll see a study where it says, the patients got weaker while they were here, whether they did therapy or not. They just got less weak if they were doing therapy. Those individuals were not doing a formalized strength training program. They were only doing a step program, like a 8-inch aerobic step, if they weren't able to get out and walk. Well, that's replacing aerobic. That's replacing strength
cardio
training for aerobic, and yet it's just it's a afterthought. So I actually have instructed my patients on how to use the new step. That's a specific machine that is very well tolerated and very popular in clinic settings. And we use it in a unique way. I don't ask them to use their arms at the same time. We're focused only on legs, and I have found a way to get them to use their leg muscles in a way that simulates both going up some steps and coming down the steps. There are two different kinds of contractions, and truly the one coming down the step is the one that has the potential to trigger increased muscle formation. So giving exercises that are sufficiently challenging, that target the key muscles that we know they're at risk of losing, is really how I try to be efficient and respectful of the limited energy that they have.
And if you're considering something in the room, and I learned this doing this Muscles for Myeloma campaign, actually, because I was researching different tips to email out to the group on a daily basis and writing different posts about it, and that was consistent. That just follows consistently with what I read, that if you had to choose between a cardio and a strength training program, you're better off choosing the strength training program. Of course, both are important, but for muscle loss and things like that, then the strength training is by far the best for even weight loss too. So,
well, that's absolutely true, and that's
want to lose weight, but
that's actually true in other populations. I found that to be true for people with spinal cord injury. When you're rehabilitating them after spinal cord injury, it turns out that they actually can improve their endurance because in building muscle, you build the vascular supply to the muscle. And therefore, in the process, the muscle, you're building and improving endurance while at the same time building strength.
And when you think about exercising even in a bed kind of situation, let's say you're on your worst days, you want to just do something small to keep those lower extremities, can you use bands? Do you ever do that with patients?
I'm glad you asked because I just was dealing with this week. I have a patient who's got a different diagnosis but in for transplant, and he came up with it. He said, I want to use this resistance band and watch, and he was putting it around his foot and holding it with his hands, and all I could picture was that band slipping off the end of his foot and snapping him right in the face. And truly we've had problems with injuries of that nature, and these people have low platelets, so that's a concern. And I also have a concern about the hygienic part of these resistance bands when people are in the hospital. When they'll fall on the floor, they have static electricity, they pick up all kinds of dust and debris. So I don't actually give resistance bands. I do what we call closed chain strengthening, which just means your foot is in contact with the earth or the bed. So, the exercises that I've found that can get people through the 0.0 phase really is an exercise we call pelvic bridging. That's going to work the glutes and the hamstrings and also the quads and the calves a little bit. And something so simple as the straight leg raise. And you would be amazed at how challenging that exercise is for people as they hit 0.0. You can actually see their leg trembling, and that is challenging for them to just do a straight leg raise. So those are my two go-to exercises once they hit 0.0. And the pelvic bridging, the only precaution I would offer there is many of my patients have compression fractures, and they can be of the lumbar spine. So with the pelvic bridging, I truly have had probably a 95% tolerance rate for that exercise, but I do have to be mindful that sometimes we have to not lift the pelvis up quite as high in order to not aggravate any of those former fractures or low back issues.
Right. So we've talked about the factors of why we lose muscle strength, and you've mentioned some things that you can do to ward off the muscle loss. What else do you see is important for patients to do? And is there a point where your platelets are at certain levels? Because I was reading something that said on a myeloma website actually that was saying if your platelet count is a certain level, then maybe you shouldn't do any exercise because you can have internal bleeding. Is that ever a caution, or you just don't see that?
Well, so we obviously need to pay attention to clinical practice guidelines on this topic, because not just for the patient's benefit, but for your own legal concerns. So when you're prescribing exercise, it's no different than prescribing medicine. It has to be dosed properly. It has to be given under the right circumstances. And so exercise prescription in cancer is actually a topic I've spoken on before. And I apologize, I don't have my reference sheet in front of me to tell you the name of this reference, but it is commonly available. And what they say is that you should not be doing high-intensity aerobic exercise if your hemoglobin level is below 8. Now, I tell all my patients on the inpatient side, you will not be doing high-intensity aerobic exercise the entire time you're here. And likewise, when they discharge, our physician team does not advocate for high-intensity aerobic exercise for 3 months post-transplant. You should also not be doing that when your white cell count is below 0.5. Well, I can tell you, anybody below 0.5 isn't doing anything. I mean, it's high intensity for them to try to get up and just get over to the commode. They could be short of breath, they could be tachycardic, their heart rate could be quite high. And then it also is recommended that the platelet level below 50, and we transfuse when people drop below 10 here. So those guidelines are truly, to me, they don't even become a factor, because for my inpatients, I tell them, you're not doing high-intensity aerobic exercise, period, while you're under my care. Because I cannot find a reference anywhere that would support me in a court of law, and I certainly don't want you to suffer the consequences of an adverse event. What is an adverse event that could happen? Well, one thing is if your hemoglobin is low, which we call anemia, which means you're usually, while they're here, if you're at 8, that's like half of normal. And so when the count is that low, these people are at risk. They don't have the oxygen carrying capacity. So just because you're exercising and you're thinking, this feels good, the problem is that you have half the number of vehicles delivering oxygen to your muscles, and your heart is a very important muscle that needs its share. So that's really important. And then, of course, the platelet level is, the concern for your ability to clot. And so I don't give my patients any type of ballistic exercises while they're undergoing transplant or even after transplant. We don't want them taking any risks where they could fall, cut themselves, or cause an internal bleed from, striking something.
Okay. And I'm taking notes while you talk.
Sure.
We have a lot of different topics, so I don't want to jump around too much. But I think we're going to end up coming back to that. Yeah, I think we're going to move to balance, but I think we'll come back to that a little bit, because you're talking about how I remember talking to you about this at Pat's beach party, and what you were saying was really important, and that refers to blood pressure. So let's talk about balance first, and then we can make sure we come back to this issue.
Absolutely. So the thing that I always remind people of is that as humans, we have 3 systems we rely on for our balance, and vision is one of them. Sensory function, that for the feedback we get from stretch receptors and pressure sensors in our muscles and joints in our lower legs, and also our inner ear. And so when you're going through transplant and you've had chemotherapy or diabetes that's given you peripheral neuropathy, now you're down to really just 2 systems you can rely on. So I'm always highlighting to people that they need to turn on the lights. They need to have a well-lit environment to see what they're doing, make sure their eyes are open, that they have their glasses on, and especially in our hospital setting where everything is, it changes all the time and they can't always predict where equipment will be or where their lines are. And so those trip hazards and things right there in the room that could make them susceptible to falling. So decreased sensation, and then what people don't realize, too, is that you usually also have decreased strength in your lower legs if you have peripheral neuropathy, especially in your plantar flexors or your calf muscles. And so that also affects your reaction time, how much you can move to clear your toe or spring up, to make a quicker movement to avoid a fall. And so those are the 2 main things, decreased sensation, decreased strength. But we address that really with my patients when I evaluate them. I will be able to identify when they walk in front of me. I can usually tell if they have impaired balance or have the start of peripheral neuropathy simply based on how wide apart their feet are. And this is an interesting thing. If you ever go out to the mall and just sit there and watch people, you'll see folks in the way they walk. There are people that are walking just fine right in front of you, but if you ask them to stand on one leg, they would tip right over. And so that is a test that I'll do, is a single limb balance test, strictly to see, how well can they coordinate and balance on one leg. And you wouldn't believe it, but we could fill the room I'm in right now. We could fill with research articles that have been done specifically to look at single limb balance. And it's been studied so extensively that you can actually plug in the patient's gender, their age, and how many seconds they could balance for on one leg, and it'll spit out a prediction of how soon what their likelihood is of falling in the next certain time period.
Wow.
So, yeah. And it's something that I think some people get nervous about, and they'll say, oh my gosh, you can't do that. These people could fall, or, if they fall, they're going to get hurt. Well, unless you're put in a position with supervision to see that you have this deficit, a lot of people actually don't even realize it. They don't realize how much they're relying on, a wide base of support or their IV pole, for example. That becomes something that my patients get quite dependent on for support while they're here. And I sneak it away from them in that last week, and sometimes I get some dirty looks, like, hey, what are you doing? I was holding on to that. So.
That's really helpful to know that. So that could be kind of a good indicator that someone could do, maybe standing close to something, so you're not you're not putting yourself at risk at all, but see how long you can balance.
And again, I do urge the audience that's listening in to not just simply go over and try to stand in the middle of your living room on one leg, because the 911 calls that will be to follow are, would be devastating to me. I have my patients standing in the corner of a room so that they're cradled backward and to either side, and they have a chair in front of them with the chair back turned so that they start out with their fingertips supporting themselves on that chair back when they actually do the training. When we do the testing, it's a standardized position, so the arms are folded across the chest. But for the actual training, we set it up in a way that they can begin to, start making good predictions and putting their foot down or putting their hand down to help prevent the fall, but to build confidence and to build, their ability to stand on one leg for at least 10 seconds. And that's the goal that I've chosen. The research literature uses 30 seconds, and I think that's just a little excessive for everyday life. But when you think about walking, it truly is single limb balance over and over.
And when you talk about falls, what else can patients do to prevent falls? I know you went through kind of an extensive process, and you were learning some new things that you were teaching people at your facility about fall prevention, because it's something that you're measured on, right?
It is.
So how do you prevent falls?
So the falls are obviously it's a multifactorial issue. We actually use a fall risk assessment scale that our nurses fill out every shift, and the topics that they are rating the patient on are elimination problems, which means do they have urgent stools? Do they need to get up frequently? Is this a new problem? So they're likely to not be, to where they figured out how to do this without rushing or tripping or falling. Their mobility and their ability to ambulate. So they're rated on how much assistance they need, and whether in the one category is if they were to be on bed rest or unable to walk. Mental status is one of the things that you're rated on. Sensory function, in other words, really your ability to see well, and that has to do with whether you're wearing glasses or not, or if they have some eye condition that we can't correct for. Medications that affect your heart and vascular function, medications that affect how your brain functions, so that could make you less alert. A narcotic would be an example that makes you less alert. There's different anti-anxiety medications and even anti-nausea medications that will depress your kind of level of alertness. And also the timing since your last fall. And then the age of the patient is also included in the total score. But the other thing that we have done as an initiative at our unit here is we've initiated daily orthostatic hypotension vital signs. What does that long phrase mean? It means that every morning, every patient will be assessed. Their blood pressure and heart rate will be measured when they're laying flat, when they're sitting at the edge of the bed after 2 to 3 minutes, and when they're standing after 2 to 3 minutes. And if the individual...
What the difference?
Yeah, if the definition of that is if the person experiences a greater than 20 millimeter of mercury drop from either laying to sitting or from sitting or laying to standing, and also if it has an associated greater than 20 beats per minute increase in their heart rate, that is considered a slam dunk. Yes, you are positive for orthostatic hypotension. The person then is rated on, are they symptomatic or are they not symptomatic? And that just means whether they complain of, oh gosh, I feel lightheaded, or some sort of a symptom like that. But the thing I want to caution people about is, I've actually been doing this type of work for almost 22 years, and especially in patients with a more chronic type of an ailment, what I've observed is that the majority of people will not ever tell you they feel lightheaded or dizzy, but they could have a blood pressure 70 over 40 in standing. And all they'll tell you is, well, first their knees will start to buckle and they'll kind of come down with a thud on the edge of the bed. And if you ask them what went wrong there, they'll just say they felt so weak. And this is actually consistent with some studies that have been done looking at advanced cancer patients, where they actually looked at those patients' autonomic dysfunction, in other words, the drop in their blood pressure. In this one study, they found that 47% of these patients had severe autonomic dysfunction. 0% reported that they were lightheaded. And 30% of our patients every day we find have a positive orthostatic finding. This resulted in us seeing a dramatic drop in the rate of falls on our unit. And we've recently had more challenges, I think because we've introduced some more aggressive chemotherapies. And so we're constantly working to try to minimize patients' fall risks in a hospital setting. Obviously, it's bad for those patients, and the outcome could really be life-ending if they were to fall and their platelets were low. So it is a very serious thing that we are striving every day to help prevent. And that leads me to one other thing I should mention about the balance that I didn't say, and that is that it's not that uncommon also for patients undergoing transplant to experience some sort of a inner ear problem while they're here. And that I would attribute that. It could be a side effect of a chemotherapy, but I think it may also be simply related to their electrolyte imbalance. So when you're having frequent stools or diarrhea or nausea and vomiting, your electrolyte balance is off, and that can actually contribute to what happens in the inner ear. And I've treated many of my patients who've had different forms of inner ear problems. And so, again, diminished sensation in their legs, maybe their sight isn't the best or the lights are dimmed, and now you add this vestibular problem, and you have a person who could fall rather frequently. So,
multiple causes. So what you're saying is in your facility you're taking 3 sets of blood pressures, and I think that's very uncommon. So I think for patients, and I've never ever heard of that before, that you could take a blood pressure laying down. You could then take your blood pressure sitting up, and then you could take your blood pressure standing and see potentially a dramatic difference in those 3. And so what you're saying is, 30% of your patients, when you do that, are having issues. They have dramatic differences in their standing versus sitting versus laying down. So that causes falls. So when you take those blood pressures and you know where that patient is at, then you know, well, I've never had that done for me in 3 different facilities.
Well, and I'm with you on that. I'm appalled on a daily basis that acute care hospitals have not embraced the fact that probably every patient every day should have this done, because if you're in a hospital, you're sick. You're undergoing changes in your hemodynamic, your blood volume levels, your fluid status. We're changing your blood pressure medications. We're introducing different drugs that you don't know how your body's going to respond to. And I'm sorry, but if I look at the blood pressure readings on my patients where the nurses have charted on them for the last 2 or 3 days, it's a sleeper for me. I would just want to yawn because, sure, their blood pressure looks absolutely fine, but who cares because they're laying down. You can make changes to their medications based on that, but the important thing to ask yourself is what is going to happen when we stand up, because that is the only time, really, that the patient is now at risk for falling down. So it's such an important piece of the patient's health status, and I literally do it with any of my new evals throughout the hospital. It doesn't matter what age they are. I find pediatric patients who can go from 120 over 70 lying down to 90 over 60 sitting to 70 or 60 over 40 in standing. And without that documentation, without me doing that set of vital signs, I can tell you that child or that adult could be asked by nursing staff or therapy staff to say, come on, you can do this. You don't need to be so worried about it. Just let's walk over to the bathroom. You should be able to do this. And it's a very gentle form of kind of, pushing someone to do something that they don't feel confident about. And they don't feel confident about it because when your blood pressure drops, you do feel a little bit of like kind of anxious, like something's not right. But you just can't always find the right words. So, yes, I think it's extremely important for folks that are going through any form of chemotherapy or who are experiencing what they might call weakness, or they might say, I'm just so tired when I get up, or some people that say, my knees just want to give out, or maybe they have an unexplained fall after they stood up. Those are all indicators that set of vital signs should be done.
And what about the myeloma treatment or having myeloma causes that change in blood pressure?
Well, my understanding, and this is, some people may want to argue this, but my experience is that people come in and they are just as strong as anybody on the street when they check in. And within a week is when we might start to see this very sudden change. And initially I was getting called to come up and reassess because Mrs. Jones is so weak she can't stand up. She's deconditioned. These are the things I was being told. Well, I'm sorry, but in 1 week, Mrs. Jones is not going to become so deconditioned she can't stand up, especially because she's been walking. She's been doing my exercises I gave her. So I think we need to be very careful about labels and assumptions that are placed on patients when, in fact, if we just looked at the objective information, we would know what the problem is. And I lost sight of your original question because I really just wanted to express that advocacy point.
Oh, no, I think that's very important. But I'm just wondering what causes that change in blood pressure. So you do feel that so weak, which kind of leads you into that fatigue feeling.
So think about the peripheral neuropathy that is caused by these chemotherapies. So there's actually something called autonomic neuropathy. So the nerves that control how your blood vessels respond, how they constrict, how your heart constricts, those are just as susceptible to the side effects of chemotherapy. And many of the drugs that our patients are given, if you read this fine print, it will say that this drug is cardiotoxic, that this drug can cause drops in blood pressure, it can cause dizziness, lightheadedness, falls. So we do have patients who literally are experiencing a temporary heart failure while they're an inpatient, which does in fact improve because we've seen their echocardiogram that was done before they were admitted, and we see it afterward, and it recovers. But during that time, they can have an echocardiogram that may show that their heart function is diminished. The strength of the contraction is diminished. And not everyone has that. That's the thing. You don't know how your body is going to respond to a given drug. There's a wide range of how we all respond to these medications. But you certainly won't know if you're not having your blood pressure checked. You know, it may just be that you're labeled as being lazy, or you're labeled as being, you know, she just won't do anything, you know, she's too anxious, I don't know why. And you take that blood pressure and you go, oh, that's why.
Mm-hmm. And so it's something patients could ask their nurse to say, I feel so fatigued. And this is normal
you
for
know,
me. You can take it 3 different ways.
Right, and you know as well as anyone that the word fatigue is such a garbage pail term, and cancer-related fatigue has been coined for, 20 years probably or more, but what is it? And that's why I really like that study that was done on people with advanced cancer that really showed that, look, there is almost 50% of these people have an autonomic dysfunction, a severe autonomic dysfunction where their blood pressure just drops every time they get up.
Mm-hmm.
And I make a lot of analogies in my line of work, and I might say, you know, if you were a car, if your wife called you and said, honey, the car is like 2 quarts low on oil, what would you tell her? Oh, I'd tell her, get over to the shop, get some oil put in there. You can't drive that on the interstate today. And these people are the same way. They need some support. And unfortunately, at this time in our medical practice, the only way we really have identified how to treat this problem is to give fluids. And this can instantly, you know, within an hour or 2, have their blood pressure improve to the point where they feel fine being up and moving, and they're ready to get back out and do their thing. Unfortunately, though, sometimes that approach can lead to accumulation of fluid, buildup of fluid on their lower extremities, and more problems with taxing the heart just because of excessive fluid. They can literally have weight gains of, 10, 15 pounds of fluid being an inpatient. So, and I've seen higher numbers actually. So it's a time, in my experience, it's a time when we just need to be smarter. And maybe that patient who is already having trouble with being able to tolerate fluid, an IV bolus to address a low blood pressure, that might be the patient that we just say, you know what, we think their fluid status is fine, it's just this autonomic thing going on. And so instead of expecting them to get up and walk the hallways, we're going to walk in the room with supervision. Instead of expecting them to get up and go into the bathroom, we're going to put a bedside commode there and a urinal. And so that gives them the safety net during this time when their autonomic function is dysfunctional. Because it will improve. It's just that there's going to be this period of time for quite a few of these folks where they experience this.
So this is temporary. And what you're saying overall, I hear, is that you have this balance, this dance you have to do between making sure the patient is safe and not doing too much when necessary, but also getting up and moving to prevent further muscle loss and damage. So you're trying to weigh that balance at all times as a care provider.
That's exactly right. Yep.
It's individualized, and so we can't say, okay, you need to get up. It's time for you to get going. Because I think sometimes it's that's a challenge for caregivers too, to know, okay, when do I encourage this patient, this patient I'm caring for, and when do I just say, hey, it's time to take it easy? And so I think your approach is great. You have a very compassionate approach.
Well, I'd like to say too, it's compassion, but it's also objective, and I think that's what can be missing sometimes in healthcare is we have so many numbers in front of us, we collect so many, data points on these people, but you really, why not use what's available in front of you? Why not look at what the numbers are telling you and knowing what someone's activity tolerance might be under those circumstances, and then just respond accordingly.
Mm-hmm. Well, let's talk a little bit about endurance briefly, and then pain, or pain management, because I know
Sure.
you have a lot to share for that. So how can patients increase their endurance?
So a lot of times, and this is going to depend on where you're at in the process, but the main thing that I'm going to advise you to do if you're in the process of undergoing transplant, or if you are post-transplant and you're trying to build back up to where you were, often you simply need to set realistic goals. And when you are discharging from the hospital post-transplant, the thing I will tell people is, look, I know you might be thinking that each day I'm just going to get better and better and better and better. But what you need to know is that it is very possible that you will still need blood transfusions after you discharge. Not everyone, but quite a few people do. So when I give them some exercise goals based on where they were at when they're discharging, I'll say, look, if today you can walk for 20 minutes and tomorrow you can walk for 20 minutes and the next day you do 5 minutes and you're just gassed, you need to be thinking it's time to call the clinic. You may be needing a transfusion. So they don't have the knowledge of every morning having their blood drawn, seeing what their counts are, and just being given a transfusion. Mm-hmm. They're having to base it off of how they're feeling and how their exercise tolerance may have changed. So setting realistic goals, I think consistency is important. So, if it's endurance, I think that's something we work on every day. It's not something you postpone, every other day, but each day you're looking to set, okay, I know I can walk for 10 minutes before I'm going to need to rest. Well, 10 minutes is a small enough or short enough walking time that I would probably encourage that person to walk for 10 minutes, sit and rest as much as they need to, even if it's 5 minutes, but get up and try to walk a second time, even if it's 5 minutes, 7 minutes. And that we call interval training. So that's really just about paying attention to your fatigue, resting and sitting down before you become fatigued, so you're not putting yourself at risk for tripping or falling or getting too anxious. If you're feeling like you're getting short of breath or something like that, then that can make a person make kind of hasty decisions that could cause them to possibly fall. Did that answer your question?
Mm-hmm. Yeah, it did. So let's talk about pain. It's easy to have the time go quickly.
Yes.
I want to make sure that if anyone has any questions, they can answer.
Yeah, the first thing I would say is, these folks, the first thing I do when I'm doing a chart review is I'm heading right to imaging, and I'm looking for any compression fractures or other lytic lesions throughout their bony their skeleton, and paying attention to any pain complaints they might have. Some of my patients have had surgeries to correct some of the pathologic fractures in the vertebrae, so that's called a kyphoplasty. Mm-hmm. So I am always paying attention to their posture and generally their ergonomics, or how they move when they're doing different things around the room. And something people need to realize is that when you have a compression fracture, it's typically the front edge of the vertebrae that collapses. So imagine a series of blocks on top of each other, and it's the front edge that collapses. That's going to tend to make that set of blocks curve to that side, right, or curve forward. Mm-hmm. And that means that when you're feeling weak and tired, if you do not have proper back support and you're sitting in a way that's making you slouch, you are not only going to wear yourself out faster because your muscles are trying to help hold you up, but also you're adding undue stress to the front end of those other vertebrae that are susceptible. So posture is really important for preventing further injury, also for energy conservation. And so I will address strengthening for these folks with a specific exercise that is not crunches and is not sit-ups. We call it back stabilization, but basically we're looking to strengthen the core muscles throughout the abdomen and even along the spine. And this can be done in a way that's very challenging for the patient and yet very safe. And it's something I'm not even going to try to explain over the phone. but certainly something that a qualified therapist could help these individuals with.
So that's one strategy is proper posture and strengthening that core so that you have that. Okay. What else can patients do to navigate pain?
So some of my patients have what we can call nerve pain or radicular pain, and that's typically coming from the lumbosacral region, so the low back area. And that can be from narrowing of the opening where the nerve comes out because of collapse of some of the vertebrae, or possibly, a small bulging disc or something of that nature. Regardless of the cause, the thing that I emphasize with my patients is, again, posture is important. When you're sleeping on your back, if you have low back pain, it's very important that you have support under your knees, keep them flexed, so that those little openings where the nerve roots exit don't become very tiny, because that's what happens when we lay flat on our back. Our low back extends and it narrows those openings. So there are a few exercises that I teach people. One of them is just a simple seated hamstring stretch. And with tall posture and the heel set firmly on the floor and the knee in extension, as a person leans forward from the hip, what they do is they stretch the hamstring, but that in turn stretches the nerves that are attached to it. And that stretch can make them just a little skinnier, but also just a little more mobile through that area where they might have been experiencing some pressure. And this has been very effective at helping to alleviate that type of pain for my patients here on the bone marrow transplant unit.
Mm-hmm. And then what about, when you talk about pain, you can also talk about neuropathy. Are there physical therapy exercises you can do to reduce neuropathy or improve it or even make it go away?
Well, so the specific treatment for neuropathy, I was glad you asked that question, because it always pushes me to go back to the evidence. And so I did a little research online, and a review just came out in February, I think it was February of this year, and it's entitled Natural Products and Complementary Therapies for Chemotherapy-Induced Peripheral Neuropathy, a systematic review. And in this article, they talk about the benefits of massage as a possible treatment for neuropathy, and that when you do massage, and I've even heard from a few patients of mine with neuropathy that they've had specific treatment to their feet, which they refer to as reflexology. But when you think of what is reflexology, it's kind of like a form of massage in the fact that you're using your hands to push different points on the feet, and it tends to improve circulation. And so I also think that sensory inputs can help, because it can create a different sensation for the brain to pay attention to, rather than the negative sensation it's getting from the neuropathy pain. Sometimes stretching can help as well with that. And then, generally keeping physical activity going so that you get the benefits, kind of that runner's high or that endorphin release from taking that walk, that actually it made you feel better by the time it was done, even though before you started you thought, oh, there's no way.
And I've had some friends who've gone through multiple transplants that exercise actually helped reduce their neuropathy. Oh, that's just, it's not scientific fact.
I know. We don't always have randomized controlled trials to support things, but another reference that was made in this article was actually for acupuncture, and I thought that was a pretty robust finding that they had. I didn't go to the actual article, but within a 3-week time period, these individuals, and they had a placebo group that got capsules, and they had the group that had the acupuncture. They showed some really significant improvements that were actually rated on standardized assessment tools. So, and that occurred over a 9-week period of 20 acupuncture sessions, 2 to 3 times a week. So, I've never had acupuncture. I've done what I call acupressure, which is very, very effective at alleviating muscle spasm in the patients that I serve. So I know that, helping to address the health of the motor point and the muscle in that area can definitely help improve circulation in that area and relieve pain.
And I just have, I guess, one more set of questions, and then maybe we'll open it up for caller questions. So be thinking about your questions. If you have a question for Melanie, you can call 347-637-2631 and press 1 on your keypad. But what about muscle? You talked a little bit earlier about electrolytes and your balance is getting off. And I know some of the drugs can kind of increase the frequency of muscle cramps in your legs and your feet. So do you have any suggestions for that, or even leg swelling?
So for muscle cramping, I mean, it depends on what type of cramping, but we know that a muscle cramp usually responds to some form of stretch. It basically helps it reset. And, I've experienced some of my own muscle cramps before, and I know the last thing I really wanted to do was to lean in and stretch it because it hurts when I first start, but that actually disrupts that particular spasm in that moment. So stretching, I would think some, again, manual therapy that might get into some of those areas of the foot, for example, where you can't really stretch it any means that, with your body, with shifting your body in any way. It might take actually getting in and manually getting some pressure on the muscle to stretch it. And then as far as swelling in the legs, we advocate for these patients in the inpatient setting to elevate their legs if they're experiencing swelling and to perform ankle pumps, which is just pulling the toes back to stretch the calf muscle. And that is it functions like the sump pump in your basement. That will help when it stretches the calf muscle. It squishes the veins, which have one-way valves, and that moves that used blood out of that area and helps the lymphatics drain. So that can be very effective. I've had patients, one gentleman in particular, I'll never forget, he refused to take Lasix. He was very frustrated with the whole Lasix process. And he said, what do I need to do? And I showed him how to use our recliner to tilt so that his feet were at the heart level, and did ankle pumps the rest of the night. And the next morning he flagged me down to say he had lost 11 pounds of fluid. And that was that was without Lasix. So that can be very helpful. I know there are some cases where the fluid can become actually move into a different space where this type of approach doesn't help, and sometimes those people actually need to be given albumin, which is a protein that helps to draw that fluid back into where it can be moved. And then we have done some work on our unit with using like tuba-grip or compression socks. It's something that I think we could probably investigate a little bit more as far as who to use them on and how best to manage people's swelling, because unfortunately the TED hose that you can get from the hospital, hospital stores, they're not custom fit. And then of course people's volumes change so much that what you think is fitting today is now kind of dangerous to even try to put on tomorrow. And so that is a very difficult thing to manage, and certainly something that patients, it's something that hinders them from really doing as much as they want to do, being up and walking as much or as well. So,
okay, great. And I guess my last question would be: we after hearing these doctors talk about the need for patients to get up and get moving and get fit, we just thought it was an extremely critical thing to address from a patient standpoint, to encourage one another to do it. When we think about building muscles for myeloma, I like that we chose it. I would like to do this on an annual basis, because we've had some patients say, you've really changed my life by doing this program, because it's consistent, it's self-directed, it's just a goal that they feel like they can accomplish. If you had to weigh in, I guess, with your opinion about doing a campaign like that or participating in a campaign like that, what would you say?
I think the first thing I would say is there is absolutely benefit in finding that peer group that doesn't necessarily push you or that you have to compare yourself to, but just that you feel somewhat accountable to, that you can relate to and say, oh, I know they're going through this too. I know they're trying to get better, and I'm trying to get better. And you share your stories, and in that way bolsters your your motivation and your courage to really get out there and do it, knowing that you're not alone and that there are other people that are going through similar difficult times, and that way you can be a resource to each other. And the other thing I would say is what I kind of said before, which is start where you need to start and work on improving you. Don't try to compare yourself to someone else, because you have no idea what other issues they're dealing with that are different than yours, where they started out, and it doesn't frankly matter. You're just trying to get better within yourself.
Right. I agree. And I think patients can feel a lot more empowered about taking care of themselves and what they can do in life. And I do think it helps them as they recover, especially from stem cell transplant or other myeloma therapies.
You know, there's one more thing I should mention, just because I failed to when you asked me about endurance, and I don't have the references right in front of me, but I know that they're available on the internet. For those people that are working on improving their cardiovascular conditioning and their endurance, something that is helpful to do is actually monitor your heart rate. So your resting heart rate when you're standing, your peak heart rate when you're exercising. And there are specific guidelines that we use to try to estimate where a person should be to get the benefit and what's, you know, a reasonable maximum for them for their heart rate. So if you're seriously looking at pushing the endurance thing, that's something that I would recommend you seek out guidelines for based on your medical condition.
And then you can track it and do it safely.
And that way too, you're not worried about, gosh, should I do more? Am I doing enough? Well, look at the evidence. How is your heart doing? It'll be informed.
Okay. Yeah, great suggestion. Thank you. Okay, we have a caller with a question, so I will bring you on and go ahead with your question.
Melanie, hi. This is Paul Alstrom, Jenny's husband. Thanks for taking the time to. Yeah. So I've been listening to the show with great interest. So I'm her caregiver.
Right.
And but she's way more fit than I am. So.
I'm not going to ask how much she paid you to say that, but okay, go on.
Everybody knows. And she's running a marathon on Friday, and I'm going to be watching.
No, but 5K, not a marathon.
It's a 5K? Okay. Yeah, maybe I'm prone to exaggeration. But very informative show today. Thank you for taking the time. And you made it very real and very compassionate about, you know, getting very practical, but also I liked how you approach things, and you put yourself in kind of an outcome-based approach, saying you took your ego out of the middle of the conversations, and it was very outcome-based. What is the right thing to do to get the patient moving versus they should just be able to get up and get going. And you're looking, and so it's that level of detail I've never heard in any of her shows. She's done 60 shows so far. I haven't heard this once. So it's a very unique perspective to bring. Just wanted to thank you for that.
Well, I feel really fortunate that kind of the universe brought us together, and I need to thank Pat Killingsworth and Patty Killingsworth for their invitation to Pat's Myeloma Beach Party, because that was truly something that invigorated my heart and got me really reinvigorated about what I do and the difference that can be made, but also how there's people out there like your wife who's setting the bar high. And so it was really great to have this opportunity.
Yeah, she's a one-woman cyclone. she's amazing at many levels. So hey, thanks again for your support. She came back and told me after the conference.
Oh, cool.
About a lot of the tips, and so I've been doing the blood pressure standing and lying down. And you're right, there is a difference. It's amazing.
Yeah, and it's, we can expect a little bit of difference when we're in a healthy state, but it's when that's a significant enough drop. And, one other thing I didn't state is one of the numbers I pay close attention to is actually a number that the layperson probably doesn't know about, and it's called your mean arterial pressure. And that's a complicated average. It's a complicated average at the top and the bottom number. You can find the equation online. There's a couple versions. But 60 is the minimum that we need to perfuse our vital organs. That means your brain. That means your heart. And normal is 70 to 110. And so for my patients, when I see a blood pressure and I go, that map is way too low to expect anything, that's a real easy line for me to draw in the sand and say, nope, sorry, we're just going to do some bed exercise. So.
All right. Well, we'll keep at it and say hi to Dr. Trico for us, and we'll keep you in our thoughts.
Sounds good. Thanks, Paul.
All right.
Thank you so much.
Bye.
Well, Melanie was cornered at the beach party by many patients asking about their specific issues. So, Melanie, we're just so grateful that you joined us today. We're thankful for all the research that's gone into your efforts and for your care, and I think we all want you to be our physical therapist at our facilities. So maybe we need to consider the University of Iowa for our care.
It would be a lengthy commute for most people, but I think on that note, what I was hoping to do in presenting on the material I did at the beach party, but as well today, is to really empower people to know what they should be asking for, to know, what is it that I really want out of that therapist who's trying to help me, because it's actually been determined in the literature that for the majority of people, whether they've had a stroke, a spinal cord injury, whatever their malady or their ailment might be, we tend to undertreat people. We don't tend to challenge them enough. We have the Division I athlete, we push them, but for those of us that are athletes of life, we don't always get that objective guidance to really be pushed to our full potential. And like I said, it's not just about pushing people, it's about doing it with appropriate inputs. So I hope that people can take away these guidelines and these stories to help them really shape what it is that they want out of their therapy sessions, because you are the consumer, and I've trained, hundreds and hundreds of PT students. I know what these kids know, what they've been taught in school. Now we should expect all of us to use that knowledge to help patients of all types.
Well, thank you so much. And thanks for joining us, because it was a very, very practical and informative show.
You're very welcome. Thanks for the opportunity.
Perfect. Yeah, thank you. All right, thank you for listening to another episode of Myeloma Crowd Radio. Join us for future shows to learn more about the latest in myeloma research and what it means for you.
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.